Hello everyone, I'm Guilherme Dias, audiologist dedicated to studying, researching, and rehabilitating patients with dizziness and vestibular disorders for more than 15 years. I'm very happy that you are here. I had great opportunities to learn and study neurotology with the world's leading references in the vestibular field. Currently, we are involving and also transmitting what we know through books and articles. Recently, I published some books associated with the Brazilian scientific community. In recent years, I had the opportunity to be a lecturer in many training courses in vestibular assessment and rehabilitation in Brazil, where I understood that there is a great need for professionals to learn how to evaluate and rehabilitate correctly. Here I publish interesting information, clinical cases, and scientific articles. This is my Instagram profile. And recently I published a new repositioning maneuver for patients with positional vertigo, with very good results with a single application of the maneuver. And I will talk more about this paper. In 2023, we had the opportunity to demonstrate this maneuver at the scientific meeting of Neurotology in Brazil. So, we created an online platform where professionals can learn in one place how to assess and rehabilitate patients with vestibular disorder, with complete content from fundamentals for beginners to advanced knowledge. We realized that the best way to learn is to combine analysis of real clinical cases with science, always, and also the step-by-step related to stages of vestibular exam and vestibular rehabilitation. This is how we do our classes. This is a picture of our platform. This class was really cool because we received people from countries in Europe and Latin America, and the interaction was very good. So, we really believe that the best way is to combine science with clinical practice, taking our students' experience. Then, recent data suggests that 10% of the world's population feels dizzy, and the impact of vestibular dysfunction can affect, in addition to balance, cognition, emotional aspects, functionality, and socialization. And knowing how to assess and rehabilitate patients with dizziness and vestibular disorders mean having the possibility to bring back a person's quality of life, expand greatly your career. Remember, there are approximately 33 million people with dizziness in the US, for example. And remember, there are too few specialists for too many patients with dizziness. Here we have a clinical case, a patient with positional vertigo of strong intensity and 2 falls in the last month. Positional assessment shows signs of BPPV, benign paroxysmal positional vertigo, and the treatment is based on repositioning maneuvers. And after a single repositioning vestibular maneuver, there is no dizziness sensation, there is no nystagmus, there is no vertigo. This always makes us very happy because there is no better professional feeling than giving that to a person. Then, in our class today, we will present clinical cases and show you how to evaluate, working in a multidisciplinary team, and manage correctly and with scientific basis. And remember, when there is a lesion or dysfunction in the vestibular system, for example, the body position and movement signal will be sent with a distortion. With knowledge and scientific basis, we will be able to identify a vestibular disorder with tests that use technologies or not. They are the bedside tests. What happens is that patients with dizziness can have peripheral alterations such as Meniere's disease, vestibular neuritis, or BPPV, the positional vertigo. That's why it's so important to evaluate the 4 pillars, focusing on the most important according to the clinical history. So, the patient can feel oscillopsia, sensation of movement of the environment, or vertigo, sensation of self-motion, or imbalance, loss of stability. It may occur due to vestibular loss, or Meniere's disease, the particle displacement, the BPPV, or bone fistula, or failure in the central integration of peripheral information due to a central disease such as vestibular migraine, cerebellar disease, multiple sclerosis, Parkinson's disease. The big question is, you cannot forget it. Know how to evaluate with and without technologies. In our complete course, we teach you how to perform the exam with and without technologies. Know how to recognize abnormal eye movements, analyzing the eye movements of the patient. Know how to assess postural control. Know how to interpret vestibular exams in general, such as the video head impulse test, the VAMP, video nystagmography. Remember, all professionals who work with patients with dizziness need to know how to analyze a vestibular test, physiotherapists, audiologists, and doctor. In clinical practice, the test or diagnosis can be wrong. If you don't know how to collect the clinical history, you can keep making mistakes. In our complete course, we will show all of this. Another question: how to treat a vestibular disorder, always with a multidisciplinary team. First, diagnosis of etiology, vestibular rehabilitation, case-specific medications, correction of eating habits, or surgery in hair case. Following some fundamental steps in the approach to the patient with dizziness, our results can be very good and impact the patient's life in a positive way. You will understand the 4 pillars of vestibular assessment, taking the clinical history resulting in 4 possible vestibular syndromes. Choose the correct exam. I will show you how to correlate each finding with vestibular disorders. These are the fundamental steps of the VOR exam, the vestibulocular reflex test, the head impulse test, head shaking test, vibration-induced nystagmus, dynamic visual acute, the pressure-induced nystagmus, very important, and hyperventilation test. So, you will have a much more sensitive and relevant evaluation of the vestibular reflex, the vestibulocular reflex. To complete the evaluation, we will perform the examination of postural control and sensor integration for balance. In a multidisciplinary team, choose the best treatment. In the last topic of our course, we will talk about managing difficult patients and real-life challenges. Remember that the course lasts 1 year of access, so you can review all the content. These are the fundamental steps for the evaluation of patients with balance disorders. You will focus on some of these pillars according to the clinical history. With these steps, you will have a quick assessment with good specificity to identify a vestibular loss. Refer you to an investigation of the structure of the bone labyrinth or central disorder. I will show you how to evaluate horizontal and vertical saccade, the eye smooth pursuit, the gaze fixation, with signs related to nystagmus, saccadic intrusion, or optokinetic nystagmus, vertical alignment, to differentiate skew deviation and the trochlear nerve pulse, action of all muscles, pupillar action and pupillar nystagmus, very, very important, related to vestibular migraine, for example. Examining positional signs will allow identifying the type of positional vertigo, including the location of the particles in BPPV, a biomechanical disorder of the vestibular system, and sometimes central signs. Be sure to do all these steps. In our BPPV topic, positional vertigo topic, I will show you real clinical cases to associate the eye movement pattern with the location of the particles within the semicircular canal in typical and atypical cases. The head pitch test is very important to identify horizontal canal BPPV. The Dix-Hallpike test is very important to identify posterior canal BPPV. The half Dix-Hallpike test is very important to identify cupulolithiasis of posterior canal. And the head roll test is very important to identify horizontal canal BPPV. And the head hanging position is very important to identify the anterior canal BPPV. And for postural control analysis, the gait analysis, extended sensor integration clinical tests. Remember, taking the extended sensor integration test will greatly increase sensitivity to identify vestibulospinal dysfunction. Dynamic vestibulospinal test, the mini-cone test, push-release test, very important, very interesting for extrapyramidal disorder, the pole test, and the gait disorientation test. So, always perform the evaluation of postural control with distortion of somatosensory information, okay, and also with head movement, very important. Here we can increase the sensitivity of vestibulospinal test. And remember, these are rapid tests with high specificity to help assess the patient with a balance disorder and its origin, always along with the clinical history. And here, examination of positional signs. It is very important, especially to identify the most common vestibular disorder, the BPPV, the benign paroxysmal positional vertigo. It's a biomechanical disorder caused by displacement of particles within the labyrinth. Our work will be, number 1, identify the semicircular canal affected by the dysfunction, that is, where the particles are, and choose the best maneuver to move the particles to the right place, to the right location of the peripheral vestibular system. You cannot forget, 5 to 10% of BPPV cases are atypical. That's why we created a specific topic about it in our course. It is treated with repositioning maneuvers, normally with immediate results with a single application. The key point is, be sure of the assessment by learning from clinical cases. Here is the big secret of success. So, the best way to the best result. Number 1, taking the clinical history. Then identify the type of vestibular syndrome, like BPPV. BPPV is a trigger episodic dysfunction. Then, choose the right exam. In this case, the positional test. Remember, the particles can be anywhere in the canal, and even outside of the semicircular canal. So, know the ocular motor pattern of each location. So, know the nystagmus pattern of each location. Here, at our balance clinic, we use some fundamental steps to diagnose typical and atypical forms of BPPV. The ball and lean test is very important to help identify the location of the particles in the horizontal canal. The Dix-Hallpike test is very important to help identify the location of the particles in the typical form of BPPV, the posterior canal BPPV. The half Dix-Hallpike test is very important to help identify the location of the particles in the posterior canal variants, the cupulolithiasis and short arm variation. And remember, these two variants occur in our practice. We cannot forget it. The nose-down test or inversion test is very important to help identify the location of the particles in posterior canal variant, the cupulolithiasis. And the head roll test is very important to help identify the location of the particles in the horizontal canal BPPV. Then, the particles can be here in posterior region of horizontal canal, or here in anterior arm of horizontal canal. And here we may see different nystagmus patterns. There is a big detail here. In horizontal canal, nystagmus is bilateral most of the time. However, relying on the difference in nystagmus intensity will lead to misdiagnosis in approximately 40% of cases. So, the best way is to combine the direction of nystagmus in the ball and lean test and head roll test. I will show you in our course. So, these are the key points for the treatment success of BPPV. Know how to identify the location of the particles through the ocular motor pattern, know the atypical variants, and choose the best repositioning maneuver for diagnosis. And remember, around 5 to 10% of cases are atypical forms. I realized that the best way to make professionals understand the atypical forms is by showing the 3D model. And remember, the best learning is to combine science with visual experience. Here, we can see some repositioning maneuvers possibilities. The DIZZINESS repositioning maneuver, our recently published repositioning maneuver, Epley maneuver, Simon maneuver, and Gans maneuver. For anterior canal BPPV, Jacobino maneuver, and for geotropic horizontal canal, barbecue rotation, Guffoni rotation, apogeotropic form. We may perform the King maneuver or Zuma maneuver. This is our paper with our new repositioning maneuver with very good results. Here we have the representation for left posterior canal BPPV. The step number 1, the particles move from the amplar arm to the apex of posterior canal. Then the step number 2, the patient rotates the head 90 degrees to the affected side. Here the particles are closer to the common crus. Then the patient sits with a tilt of the head and the head rotation 45 degrees to the affected side. So the particles move from the common crus to the utricle with very simple steps. Note that this maneuver is very interesting for busy patients and those with mobility difficulties, since most of the time we use narrow stretchers or a patient with orthopedic restriction that prevents lateral decubitus position. Another important point, the final position, the step number 3, prevents semicircular canal conversion, the canal switching. So, the present study obtained a success rate in 85% of patients after a single application of the new maneuver, and in 94% success rate with 1 or 2 maneuvers performed on the same day. So, we had interesting results with 1 or 2 maneuvers on the same day, mainly in comparison with other repositioning maneuvers. So, we have one more option for patients with posterior canal BPPV, especially patients with difficult for lateral decubitus position, for example, on the narrow stretcher. Here you can see a right side posterior canal BPPV, step number 1. We may see the typical nystagmus pattern for posterior canal. Intense nystagmus. Then step number 2, the patient turned the head 90 degrees from the center line. Here, the head is closer to the shoulder and the particles are closer to common crus. Then the patient will sit with head tilt down and rotation to affected side. After 60 minutes, there is no nystagmus, there is no vertigo. With a single application of the new maneuver. This patient felt strongly dizzy in the simple day-to-day movements, such as tilting and extending the head. This is the ball and lean test on horizontal canal BPPV case. And remember, it's more sensitive to identify the side combined with the head roll test. And after a single maneuver, a single repositioning maneuver, 30 minutes later, there is no nystagmus, there is no vertigo sensation. And remember, repositioning maneuver is a precision treatment for positional vertigo based on our ocular motor pattern results in the diagnosis step. And here, for the hyperextension movement of the head, there is no nystagmus, there is no vertigo. For example, this is a class from our Neurotology education platform. We show you how to do the repositioning maneuvers for each affected semicircular canal. However, what works very well is learning from real cases, seeing what happens to patients on a daily basis. It makes all the difference. Another key point in learning repositioning maneuvers is to understand them based on 3D model demonstration. Because here, you won't just memorize the maneuver, you will understand the maneuver. Another very important step is the ocular motor examination. Here, we will have information about the central system that controls eye movements. That is, here we will have central signs and sometimes from the peripheral system, but in general, central information. Look here, central vestibular disorders are in third place, and we note among professionals that there is great difficulty in identifying these. But see, these are the fundamental steps to identify this. Remember, 90% of central vestibular disorders show us ocular motor signs. Pay attention to these signs. If you know this, your exam will be much more sensitive. Especially in saccades, you can never forget to evaluate trajectory, velocity, accuracy, and latency, even if you don't have technology. That's why we are going to show you how to interpret eye movement in real case from our collection. During smooth pursuit, assess refixation saccades as well as conjugate eye movement. During the gaze fixation test, assess the pattern of nystagmus and also how to identify saccadic intrusions such as square wave jerks or ocular flutter. And there are different types. Another important sign, very frequent in vestibular migraine, is pupillar nystagmus. Evaluate different ways the central nervous system suppresses the VOR, the vestibulocular reflex. For example, we often use the VOR suppression test with pendular rotation, and during the head shaking test, tilt suppression. Very simple steps to assess the central nervous system, especially the cerebellum. Again, With few simple steps and specific knowledge, we can evaluate eye movement. And remember, with or without equipment. Know the signs that each region can show in the central patient. And remember, if you know this and combine theory and practice by analyzing real cases, you will know how to recognize the central sign. So, again, don't forget these key steps. Okay? It's really very, very important in your clinical practice with vestibular patients. Here we can see an example of a central vestibular disorder from our collection. Here we have a patient from our collection. History of imbalance, we identify cerebellar ocular motor signs, and the neurologist of multidisciplinary team identifies cerebellar ataxia and polyneuropathy. And after a multimodal therapy, which we'll show you in the complete course, we had an improvement. Here, we use vestibular and motor rehabilitation, photobiomodulation, and antioxidant therapy. Therefore, we have specific topic in our course only about resistant and difficult cases. Remember, the best way to the best result, taking the clinical history and identify the type of vestibular syndrome, then choose the right exam. We cannot forget it. To identify a central disorder, it's very important to perform vestibular ocular motor exam. Okay? And vestibulospinal reflex assessment to develop personalized vestibular rehabilitation therapy. Here we can see another clinical case. A patient with cerebellar ataxia, bilateral vestibular loss, and neuropathy. Before the multimodal treatment strategy, severe imbalance, and after multimodal treatment, we can see reduction of ataxia, and now she can stand on an unstable surface and also perform a dual task. Again, best way to the best result, taking the clinical history and choose the right exam, always. Here, we can see two neurological patients with different diagnoses. How they were identified, ocular motor examination, and clinical history. So focus your attention on knowing how to evaluate eye movement too. So even without equipment, you will be able to identify a central sign. Here we have a change in the conjugate horizontal movement, and below, change in velocity and trajectory of the saccade. So, during the vestibular ocular motor assessment, you will need to know the peripheral and central signs, like this. This is perverted nystagmus during VOR test, the vestibular ocular reflex test. Then, I will show you step by step for functional diagnosis through vestibular exams, including the analysis of real clinical cases. You will access to 15-year collection of our specialized center in balance disorder. In addition to the classes, the cases will have specific comments on the findings. For the VOR assessment, we can use tests with technology or without technology. Our main purpose are to identify vestibular loss, signs of vestibular asymmetry, and signs, for example, that are more common in neural disorders such as hyperventilation-induced nystagmus. If you take these rapid tests together, your sensitivity will increase to assess vestibular loss, anatomical dysfunction, for example, third window syndrome, or neural disorder, for example, vestibular nerve impairment. Keep in mind that each exams evaluate the VOR at a specific frequency, so they are complementary to each other. Another important point is that each exam can assess a different structure of the peripheral vestibular system. In our course, we demonstrate the technique of examinations and interpretation with analysis of real clinical cases. With few simple steps and specific knowledge, we can evaluate the vestibular ocular reflex with or without equipment. And remember, the eyes are the window of the vestibular system. Here, we have an example of a bedside test for the viewer, the head impulse test. Here, we can see normal function, no vestibular loss. Head velocity equals eye velocity. But here, the patient has vestibular loss. Eye speed does not equal head speed. So the patient has the corrective movement, the saccades. Here, the patient will feel dizziness like oscillopsia, and we will rehabilitate through rehabilitation exercise to improve the VUR function, the VUR adaptation. Here, in our center of balance, we rehabilitate VUR prioritizing different paths and based on physiology. It's important to use the correct frequency, adapt it to the patient, and also bring into the context life. For example, mobile visual background. This is the vibration-induced nystagmus test. It is very fast, low cost, has a lot of research, and helps to identify vestibular asymmetry from different vestibular disorders. In this patient, the evaluation was very important because in addition to Parkinson's disease, he also has unilateral vestibular hypofunction. This changed everything in rehabilitation because we'll need to use methods aimed at vestibular rehabilitation and postural control. I will show you strategies to rehabilitate this type of case, okay? First, it is very important training and recognition of normal bedside examination. And also, the practical demonstration of the use of technologies in vestibular assessment. Again, how to treat a vestibular disorder. The vestibular rehabilitation is a very important step. We use a specific exercise that improves central compensation through VUR, VSR, and cognitive strategies of perception, memory, and attention. For some vestibular disorders, vestibular rehabilitation is the main treatment. For others, vestibular rehabilitation is a complementary treatment, but very important. The big point is, in disorders in which vestibular rehabilitation is complementary, in these cases, vestibular rehabilitation can make a difference in prognosis, even if it's not the primary treatment. Keep in mind that there is a great scientific potential for vestibular rehabilitation to treat vestibular dysfunctions. I will show you in this specific topic how to treat each kind of vestibular dysfunction with reasoning, using science-based techniques available for clinical practice. Here, we show how we work with a multimodal approach, where we simulate the visual vestibular system, somatosensory system, and cognition. The big point is knowing when and how to use this strategy. For example, when the patient complains of visual vertigo, you should know how to train the visual vestibular system to receive static and dynamic stimulation. So, vestibular rehabilitation can help VUR adaptation, treat body balance, include relevant postural control strategies, decrease motion sickness, very, very important. We may see very interesting results in our clinic. Decrease visual vertigo, improve impaired cognition in patients with vestibular dysfunction. We can improve executive function, memory, attention, and visual spatial ability. stimulate vestibular perception and body awareness. So, we can use vestibular rehabilitation with very interesting results in stable vestibular lesion, central lesion, head injury, psychogenic vertigo, elderly with dizziness, and after successful repositioning maneuvers for BPPV when there is a residual dizziness. Especially in visual vertigo, expand your clinical view to congruent and incongruent visual vestibular stimulation. If you are not careful here, your patient may have residual symptoms after vestibular rehabilitation. This is because there is a change in the pattern of cortical activation that can be improved with specific visual vestibular training. And we are going to show you, in the specific topic of vestibular rehabilitation, how we do in our clinic. And remember, always perform an assessment focused on the 4 pillars before you start vestibular rehabilitation. Motion sickness is a very common disorder where the patient feels dizzy and nauseous in means of transport. In this study, we can see an important reduction in motion sickness with visual vestibular training. In our clinical practice, we have seen many patients benefit from training with visual vestibular exercise, inspired by the latest research. Many are able to take a bus or car with a great reduction in symptoms and without having to take medicine for motion. I will explain these theories to you and how we can use these strategies in practice. At our Balance Center, we use visual vestibular training techniques that manage to improve symptoms in most of our patients. But remember, patients with vestibular disorder may experience cognitive impairment due to the relationship and connection between central vestibular areas and cognitive areas, including memory, attention, navigation, and executive function. These are the strategies we use in our Center of Balance and Neurotology in Brazil. In our practice, we have seen great benefits by following these steps: stroop task, exercise with numbers, double motor and cognitive tasks, mental rotation task, spatial memory, visual spatial cognitive training, and movement and verticality perception. You will be able to download the resource we use to train cognition within the online platform. This patient had severe imbalance after cerebellar stroke. After 4 weeks with multimodal treatment strategy, we can see significant improvement in the balance. Here we can see vestibulospinal reflex stimulation with double task and executive function training. And here, another example of our collection. Especially when postural control fails, for example, elderly or central conditions, we may include simulation of body awareness and movement perception in motor response. Here you can see an interesting result. My big question is, how could I do more to help professionals build confidence? How could I create something with the potential to transform your career? So, we have our online course, Vestibular Assessment and Balance Rehabilitation, where we already had more than 1,000 students. There, you will have access to a complete program in assessment and rehabilitation, with classes and access to clinical case studies, with 1 year of access, with 100 recorded lessons, PDF material for each class. Watch the class wherever you want. Support group. Immediate access. Available for 1 year. Basic to advanced content for beginners and experts. And also analysis of clinical cases from our collection. It's your opportunity to learn how to evaluate and rehabilitate patients with dizziness and vestibular disorders through a complete training course. All vestibular exams, ocular motor examination, positional tests, and vestibular potential exams. And also vestibular and balance rehabilitation techniques and repositioning maneuvers. Come live this experience. And remember, registration ends soon. I see you on the online platform. Thank you very much.